the optimal Curie score when we did our statistical analysis was 0. If you wanted the best outcome, have a Curie score of 0 going into transplant. However, it didn't mean that patients who had a Curie score of 1 or 2 or 3, that all was lost. No, they just didn't do quite as well going into tandem transplant as those that had a Curie score of 0. And as a parent, I guess you could ask me, at what level at the University of Michigan would you absolutely not do a transplant? Well, what you'll see is this. Just watch my hand. If you have this level of outcome with a Curie score of 0 going into tandem transplant, if it's a 1 or 2, maybe the outcome is a little lower. But as you start getting to a Curie score of 5, 6, and above, and going into tandem transplant, now the outcomes of transplant really start dropping off. This is where the art of medicine comes in. At the University of Michigan, we'll still take patients into transplant who have Curie scores obviously of 0, 1, and 2, maybe even 3. But as our patients start getting closer to a Curie score of 4 and 5, I really start thinking, maybe we should do some bridging therapy to try to knock that Curie score down to a lower level, 3, 2, or 1, or 0 if possible. Every center will have their own art of medicine for what Curie score they'll take now in this tandem transplant era. So if you hear that your son or daughter doesn't have a Curie score of 0 going into transplant, it's not the end of the world. It just means that when we did this pretty extensive statistical analysis, those that had a Curie score of 0 obviously ultimately did the best. But if you have a Curie score of 1, 2, maybe even 3, it's not like it's that bad either going into tandem transplant. But I would caution for anybody listening, just having seen all these Curie scores, I would caution anybody going into transplant with a Curie score of, say, 5, 6, or above. It's like, we just couldn't do it at our center. Maybe other centers would do it, but we just couldn't do it. I think one of the, I mentioned a landmark article during one of the initial questions you had for me was Kate Mathey's article that was published in 1997 in the New England Journal of Medicine that compared transplant to extended chemotherapy. It gave the platform or the foundation for what we now do with transplant as consolidation therapy. Other landmark articles transplant-wise, certainly Julie Park's article that was published in the Journal of the American Medical Association in 2019. This was the Children's Oncology Group's randomized clinical trial that compared single transplant to tandem transplant as consolidation therapy, showing a pretty clear-cut winner in those patients that were receiving the tandem transplant over the single transplant. And though every parent who's been through tandem transplant will kind of like grimace their eyes, groan with the potential side effects of transplant, to this day, tandem transplant still provides, at least with the backbone that we use, Cytoxan thiotepa for the first transplant and carboplatin etoposide melphalan for the second transplant. That tandem transplant platform still provides the optimal outcome for our patients, at least within Children's Oncology Group. So that's the second article, landmark article I give you. A third landmark article is Alice Yu's article in New England Journal of Medicine in 2010 that established the role for antibody therapy. This antibody therapy is now given to all patients after transplant and radiation therapy. We call it immunotherapy. But there's another article that I'd like people to look at if you're watching this. Ami Desai at Northwestern in 2022 published in the Journal of Cancer. A really good article that I think deserves more publicity than it gets. And Ami actually looked at what was the best post-induction therapy for patients with high-risk neuroblastoma in those patients that had Curie scores that weren't 0. Okay. And what Ami did is she broke her patients down into 3 cohorts. And this is all based off Children's Oncology Group data. And cohort 1 was a group of 123 patients, I think it was, that said, all right, we don't have progressive disease, we've got a partial response or stable disease, and let's just go right to transplant, regardless of what the Curie score was. Group 2 was you had a partial response or stable disease, so you had a Curie score of something, it's not going to be 0. and he went on to get bridging therapy and then still went on to get transplant. And that was roughly 50 or 51 patients to my recollection. And then the third group that AMI looked at were patients that said, all right, we've got a partial response to induction therapy. We've got stable disease. By the way, stable disease to a parent, what that means is basically what you came in with is close to what you end up with at the end of induction therapy. So the third group in AMI's study were patients that got bridging therapy, but then never went on to get transplant. So what did she find in this publication? Again, I view it as a landmark publication. Well, she found that the third group didn't do well. That patients who got some type of bridging therapy but never went on to get transplant had inferior outcomes over the first two groups. Again, the first group just went straight on to transplant. The second group got some bridging therapy and then went on to transplant. The point being that for patients that have a Curie score that's over 0 at the end of induction therapy, getting transplant was still a benefit. Ultimately, if you looked at patients that had stable disease at the end of induction therapy, the group that had the highest benefit, where they had the best outcome, were those patients that had bridging therapy of some sort, followed by transplant. I keep using the term bridging therapy. I view it as a detour to transplant. You're here, you finish induction therapy, you got to get to here to transplant, so you do a transplant detour. Now, the two typical means for bridging to get to transplant that we've used as investigators around North America is either chemoimmunotherapy, in which case chemotherapy is combined with a monoclonal antibody, an anti-GD2 monoclonal antibody, or MIBG therapy. MIBG therapy, many parents will know, is that radiation-targeted therapy for the neuroblastoma. So I think the key that parents should know listening to this is that, yes, if you have a Curie score of 0 at the end of induction therapy, definitely everybody in North America, Europe, I'm sure, would feel the same way. Go on to transplant. For those that have a Curie score above 0, you know what? Even if it's 1, 2, at least at our center, or even 3, we're likely to take you to transplant. If you have a score that's higher than that, we would advocate bridging therapy of some sort to get you down to a level that we could then take you to transplant. That bridging therapy may be chemoimmunotherapy, and maybe MIBG therapy. I always like to quote Woody Allen. Woody Allen once said that 85% of success is just showing up, meaning that if you've got a high, elevated Curie score at the end of induction therapy, 85% of success is just showing up. Do something, okay? Don't just sit there, do something. And the two main options is chemoimmunotherapy for several cycles. Oftentimes at our center, we'll give 2 to 4 cycles of chemoimmunotherapy and then relook at the Curie score or disease status. Or we'll do MIBG therapy, and then if the Curie score comes down, then we'll go to transplant. It's not the be-all and end-all for deciding if you should go to transplant. It's a tool. And if your child doesn't have a Curie score of 0 going into tandem transplant, it's not the end of the world, okay? It's just a tool, okay?